started. So welcome to the audience today to our Cigarette Restitution Fund Lunch Learn Link seminar. We have a special speaker today from the NCI. Our seminar is sponsored also by the Cancer Outcome and Health Services Research Group here at the Cancer Center and in the School of Public Health. So the talk is being recorded, so if there are other colleagues of yours who you know would like to view this later, we will be posting it on the internet and on our Cancer Prevention and Control website. So today we have Dr. Shobha Srinivasan from the NCI. She is in the director's office and is senior advisor for health disparities. And she was just telling me she wants to help us develop the vocabulary and the nomenclature for discussing disparities and the needs in populations. And today she will focus on persistent poverty and its relationship to cancer mortality. So Shobha, I welcome you to Lunch Learn Link.
Thank you so much. I'm going to try and share my screen. It's always a challenge for me, I find. Hey, yes, you can see it now, right? Okay. So today, actually, I changed the topic a little bit. How do we serve our communities and rethink our methodological assumptions is what I'm going to try and talk to you today about. And within that, if we want to do work such as in persistent poverty counties or address issues of SDOH, I'm trying to kind of have us revisit some of our assumptions before we move forward. So, as Thomas said, I'm in the division of cancer control and population sciences. So I'm going to just go over very quickly our definition, our portfolio, and what is our lens in doing the work that we do. Some of the signature agendas, so we don't call out poverty, but it's embedded in it. And what is our future planning in this area of work? Okay, this is interesting. Next. Okay. So we have four programs, behavioral, epi and genomics, healthcare delivery, and surveillance. And we have three cross-cutting areas: implementation science, cancer survivorship, health disparities, and health equity. I just want to let you know that if you have any questions at any point in time, please don't hesitate to ask it. And I'm glad to have a discussion on any particular issue. So disparities at the NIH level has generally been a very narrow definition, but within the division that I work in, we've had a very broad definition for more than 18 years. So we take into account not only SES and race, but we take into account gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, and other factors historically linked to discrimination or exclusion. And I bring that up because we have some programs specifically trying to address those issues and trying to bring the communities, at least try to learn from communities how we can address them it's a better way of putting it. So accordingly, this was way back early, I'm tempted to say not late 2018 or something like that. Some of us got together and we were talking about how we could get to equity. And the problem for us was, we talk about doing work in this area, but our work is very ephemeral, meaning we come into it, we do it, and we say, check, move on. And that's a very big problem. And so what we felt was this area of focused and ongoing societal efforts was a very important agenda for us to do any of the avoidable inequalities in health, and how we can address issues in healthcare disparities and elimination of any contemporary injustices. So, as I said before, we would like to eliminate cancer-related. Yeah.
Shobha, excuse me. I had a question about your last slide. How would you measure health equity? Have you all discussed that?
Yes, we have been having deep discussions, because I think health equity for us is how we get at the SDOH issue. So that's the poverty issue. So health equity is trying to deal with the structural and institutional imbalances. So it is those structural issues and whether we are able to affect it.
Okay. Thank you.
Not at all. So when we were, one thing in the government is, I don't know how many people know this, we have to plan way in advance, meaning if you want to put out an agenda, it takes us about 2 to 4 years to put out an agenda. You have to go through every check and balance. So when Biden took office and he put out this executive order, which was his first executive order as president, he included this area of persistent poverty or inequality. And luckily or funnily or opportune moment, we were already working on these issues, and we had a paper which was published last year on persistent poverty, looking at not persistent and not persistent poverty counties across the US. So we were able to build on this agenda. So we have about 800 to about 900 applications within the division. We code all our grants internally on areas of science that they address. What we are particularly interested is in the medically underserved populations, based on the definition that we have, based on gender, age, race, ethnicity, education, income, class, disability, geographic location, and sexual orientation. I'm going to come back to this because it's a very important agenda as we deal with our biases. So this is just kind of like, if you're in the division, people love to talk about this, how our portfolio in disparities has grown. But what I'm much more interested in is how the portfolio has grown in the medically underserved population. That is, we are not comparing Black to white, but we're looking within the African American, within the Black, within the AIAN community. What are we doing to shift the needle? And I'm going to keep coming back to this issue repeatedly because we have not moved the needle, because we're comparing two completely different groups with completely different social contexts and realities, and we're thinking they all are the same. So my favorite one is a green cabbage and a green apple. You're going to compare how the two taste, and they taste completely different. One, you can eat raw cabbage, you can eat raw, but it doesn't taste as good. But what is the point of that comparison? So we have this kind of saying everything has to be compared to a standard of some sort. We don't know where that standard really came from. Okay. So our lens is just like, whether you went to Venice or you went to the outside of Florida, where people live, the context in which they live becomes important to us a lot. It's not relative, but it is a perspective that we have to take. So we know the social determinants framework, and we talk about context a lot, and we talk about how individual and structural and institutional factors affect and interact with each other across the life course. However, most of our studies talk about, are you compliant with the screening and prevention strategies? How often do you go see your doctors? Are you really up on your vaccinations? Not talking about these social structures of society. Do you have is transportation available to you? Are clinics open and the hours that you can go to? Most people who are poor work 2 to 3 jobs. It's impossible for them to make it to the doctor's office 9 to 5. So what do? Do you have office hours which are outside of the 9 to 5, Monday through Friday? Have we ever changed our thinking on that? No, we haven't. So a lot of the problems are structural, but we blame genetics, we blame biology, we blame the fact that a person smokes, a person drinks, and it's all there, but it's all due to these issues which are structural. So we have to go beyond the individual into community and policy and contextualize our work. And until we learn to do that, I don't think we're ever going to move the needle and move towards equity. So some signature agendas which might help us. So this is going to be a challenge for us going forward. SEER has expanded. You know about SEER, right? I hope everybody knows about SEER, the Surveillance, Epidemiology, and End Results. We are charged by Congress to give an annual report to the nation, and it's generally based on race. Now, if people are not cognizant of it, within the US Census, 28% of the population said they are mixed race. Now, how are you going to report that? I want to know. In 1990, when I was on the advisory board to the census, we had 2% of the American population, and the US Census came out with an algorithm. Now we have 28%, and this is only going to get more complicated. So this is going to be a big challenge, but SEER is expanding, hoping to get larger groups of people included within its realm, which will help us. I don't know why it keeps going backwards. So touchy, isn't it? So the other area is, and I also want to tell you this in the SEER, is we are also trying to, within these areas, look at poverty issues, look at income issues, because we kind of put the data in line with the US Census and the ACS. So that helps us analyze that data, and we are working on something which I will talk about in a little bit. Survivorship, we have a new director for survivorship, Emily Tonoresos, who's come in, who's been here with us for a year. And there are a lot of issues that she is trying to address. So and all of it is in low income communities, whether urban or rural. So how do we kind of support caregivers? What are the issues of palliative care? Palliative care, for example, we just assume end-of-life issues are easy to deal with, but there are a lot of cultural issues. The first time we've ever funded an application on palliative care in American Indian communities was 2 years back. We don't have any knowledge even about how to deal with the issue, which is so we are really behind the curve on these kinds of things. So one of the biggest, as you all might have heard, the Cancer Moonshot program was a big thing, which had 10, among the recommendations was to kind of take the research and implement it in the community right away so that it affects people's lives. Nowhere did it say it had to be kind of in a particular community or not in other communities, but interestingly, it ended up being in all the underserved, low-income poverty areas across the US. So the 5 programs capture rural Appalachia, rural African-American populations in North Carolina, urban populations, African-American and Hispanic populations. Oregon gets Hispanic and white populations, and San Diego is getting rural and urban Hispanic and African-American and white populations. So here is a group that is totally devoted to this. But if you notice, we are missing American Indians in this group. So we funded a parallel effort through the cancer centers to 3 cancer centers, to Arizona, New Mexico, and Oklahoma, to address challenges in the American Indian community. Now, the American Indian community has a very complicated healthcare system. So there is a tribal system, there's an urban system, and then there's the IHS system. So, and each system works differently in each reservation and the urban areas. So this is kind of like a pragmatic trial, if you could say, because each clinic is so unique and each population so unique that you have to look at these issues and address it as they come up. So this is kind of teaching us as to what the community needs and trying to address the needs of the community. So one of the biggest programs which took to heart the comparison to comparing two totally different type of situations was the rural health agenda. In the rural health agenda, we did not allow comparisons to urban. Believe it or not, we got such a lot of pushback. One person at a review group said, "How will I know the rural is doing well if I don't have an urban population?" So I said, "How did you know urbans were doing well without a rural population all these years?" So the thing is, we have these biases inherent in us. We don't even realize how we do things. For example, a person took a rural intervention of going to a YMCA and trying to implement it in rural areas. And I'm thinking, do you know how people live in rural areas to kind of go to a YMCA? Where are they going to get that? People don't even think about this, but they think, oh yeah, this physical activity intervention in an urban area should work very well in a rural area. It doesn't happen that way. So this was a specific initiative which said these people who live in rural areas, though they might have lower incidence for some cancers, have higher mortality. Now that is a systemic issue. So how do you address those systemic issues? How do you build these efforts in rural areas? So we have two programs in that, one on care coordination, which went through 2 cycles. And also now we have 2 cycles of the prevention program. We just did the funding plan for the first cycle, and the second one is the applications are due soon. The other agenda which we have really worked on and which has taken off because of COVID is the telehealth research, telehealth agenda, and their P50 Centers initiative to see how really we can reach these populations. And this was going along very slowly for a long time, about even the last 10 years, but COVID really has been able to spur this agenda, as everybody knows. And this is very important, especially in underserved communities. Coming to persistent poverty. So as we know, persistent poverty is defined at a county level, and which means that there's very few areas across the US which are really have areas that are persistent poverty. So what we did was I'll come to what we did. But we know the unique characteristics of persistent poverty, and this is actually from a study by the USDA. There's greater unemployment, inadequate access to healthcare. There's, of course, obesity, smoking, HPV infection, food insecurity, which is a very big issue in these areas where there's not even any grocery store, lack of adequate housing, environmental degradation, low educational attainment, greater minority and structural racism experiences. So what we actually found in a study that we did with CEBP, which was published in 2020, was overall people in persistent poverty counties tend to die have a higher mortality than people in non-persistent poverty counties. The other paper which we're working on and actually just finishing up is a paper which follows up on this and looks at persistent poverty, rurality, and race. And it just is looking at, and it's very interestingly, it is like rural Blacks are seeing the highest rate of mortality than rural whites or rural urban whites even. So this is kind of telling us that we are not developing good programs which are specific to the needs of people, and we need to be able to do that. So one of the first agendas we got into was looking at the definition at a county level. You cannot do an intervention at a county level. It's impossible. So many smaller areas of extreme poverty are excluded, like District of Columbia is excluded completely from it because it's one county. So we worked with Tracy Farragon at the USDA, who defines persistent poverty for the US. And we have extended the definition to the census tract level for this funding announcement that we are putting out, a U54. So it has broad representation across all states, including Puerto Rico. And actually, we're able to double the population that is in persistent poverty, which is a much more accurate measure, from 16.5 million to nearly 29 million people. We're going to make this data available within a month or so, but you can see that it is across the country and it's huge swaths. And of course, more in the dark blue. This is a heat map, more in the dark blue areas and less, because also you have to understand there's a lot more open land space in many of these other areas. So this is from USDA again. What happens in persistent poverty areas, a greater likelihood of lack of adequate support services. One of the big things that they found in persistent poverty areas. Exposure also presents a barrier to well-being, ability to access medical services. You know, in rural areas, people say when you fall sick, you get a one-way ride. Meaning the ambulance will take you to the hospital. Who's going to bring you back from the hospital home? You don't have the money. So it's called a one-way ride. And people really think 100 times before they call the ambulance. So it's also a double poverty exposure, meaning if you're in a persistently poverty area where 20% of the population is below the federal poverty line for the last 30 years, you're dealing with generational poverty, and it will perpetuate from one generation to other, because your own poverty and the fact that there are no resources and there's structural imbalances there keeps you at that level, and the lack of mobility and a lot of dropouts from high school with lack of job opportunities and those kinds of issues persist. So the aim of this initiative is to use existing data and also to bring new data in, conduct multi-level, multifactorial interventions, and also help train the next generation of researchers in doing this kind of work in persistent poverty areas. So actually, we did an analysis of the entire portfolio, and believe it or not, it was really sad. We found across NIH, there were only 5 grants in persistent poverty, and Ayala's grant is actually a supplement. There is 2 R21 and 2 R01. So, you know, we really have nothing that's going on in these areas which kind of look at the issues people are facing here. This is something you can even look up in the reporter. You can look up these grants in the reporter. So what we did is last year in the summer, we announced a supplement to cancer centers, and we funded 5 of them. And we encouraged them to reach out of their cancer center catchment area and go to other areas which are in persistent poverty. So for example, Roswell Park created a partnership with Arkansas in trying to address persistent poverty issues in rural African-American communities. Vanderbilt reached out to Mississippi and Arkansas, and they are looking at persistent poverty issues in African-American populations in partnership with 3 FQHCs. Abramson is doing work on colorectal cancer in Philadelphia County. New Mexico is looking at cancer survivors, Hispanic and Native American, and largely based on food insecurity issues. And the last one is the UT San Antonio, which is looking at border issues in the Rio Grande Valley. So I'm coming now to the point at which, what do we need to do this kind of work? And I feel very strongly that until and unless we kind of rethink how we do work in these areas, we are never going to get at the problems. This is like we're creating a job security for ourselves, is what I tend to say. We call people underserved. We say they are hard to reach. Basically, what it means is hitherto not included populations in any study ever conducted. Basically, that's what it means. So we say geographically underserved, and that is basically for people in persistent poverty, rural, people whom we don't acknowledge. It's ubiquitous. Poverty is ubiquitous. We just don't see it because we don't want to see it. If I tell you that 40% of America is below the 200% poverty line, you would say, no way, Shobha. But it's true. But we don't acknowledge it. We don't want to see it. So population groups that we would like to look at is sexual gender minorities. Subgroups of race ethnicity are very important. Researchers, even me, and NIH, NCI, I can speak on behalf of NCI and my division, we say populations are hard to reach, which became a bone of contention recently at our joint board of meetings. They said, we don't want to hear this word hard to reach. It's hard to reach for whom? They live there. You just don't want to go there. One of the things we say is, this population is too limited in size and power calculations are a problem. Really? You're going to wait until the problem gets so huge and then you want to address it? Somebody was looking at cervical cancer issues in the Haitian population in the Miami area. And one of the comments made by reviewers was, the sample size is too small. And I'm like, okay, you want me to bring in more Haitians and then you want to do the study? What is the point of what you're saying? I want people to explain it. Let's generalizability. And I'm going to come back to this point. It's the most sticky point. Generalizability to whom and for what? Then we have this wonderful statement that we say, limited return on investment. If I spend money on 100,000 people, it's much better than my spending money on 1,000. So if that is the case, guys, I think spend all the money in India and China. You'll get a lot of people in the world every time. You won't have a problem with limited sample size. But that's not the way we do things. So let's think about our biases. So we say, also, we exclude people through the interventions that we design. We say we're committed to RCT, and randomization is a challenge with limited ability to recruit. You can do quasi, which is really fantastic in these areas. We say it's a problem to recruit populations that are spread over several states, and the social contexts are different. Is the intervention, so in all this, my question is the fidelity to the intervention important or to change the lives of people? So as long as we're going to hide behind our science, we're not going to move the needle any further. And we say cross-contamination of the intervention is high in some areas, which is true. So how do we account for it? How do we really measure those issues as we move forward? We never account for the context in which people live. So, for example, here we have a colorectal cancer screening intervention, which was proposed, which didn't get funded, but said everybody will be offered childcare services. Really, at the age of 60, I want childcare services, or do I want transportation? Or do I want something else? No. Everybody has to be offered the same thing. So we have to find out what is the context that people are living in? And we have to take into account how the stressors get under our skin. Until and unless we do that, we're not going to account for the social needs of people, and we're going to never move the needle. So we have this bias, whether it's implicit or explicit. Why is it important, I come back, to compare dissimilar groups? Why is the white group the benchmark? Why do journals and publications require it? So when I'm doing an intervention, an R01 intervention is $5 million. Let's face it, $1 million a year. And you're saying, I'm going to do a nutritional intervention, and you have this nutritional program. And who is that nutritional program judged against? You're going to say you've got to have quinoa, and you're going to have whole wheat, and you're going to have fruits and vegetables, which low-income folks don't have much access to, and quinoa is not covered by your WIC. So we need to reconsider what is it we're suggesting to people. There have been studies or food studies where they've taken people and they said, oh, if we cook certain foods and give it to people, they will lose weight. Of course, if someone cooks for me every day and provides me three meals and, in a portion size, I will also lose weight. But that's not the life of people that we are trying to help. We're not taking that social context into account. And most interventions are calibrated to the white population. So even before we start the intervention, I'm going to tell you the whites are going to do better than the blacks. Yes, the blacks are going to improve, but not as much as the whites, because you've calibrated it to the white population. So what is the point of that comparison? And what are we controlling for? Are you controlling for race, which you cannot change, or the social context, which you can change? So be clear on what is it you're controlling. To date, I can tell you, there is no intervention on the face of this earth that has ever been developed, which we don't change when we implement it in another community. People don't think about that. So when we say it should be generalizable, what is it you're trying to generalize? To whom? And what is the outcome of that? So it's much more important that we compare similar groups. So if I tell you that people in persistent poverty should be compared to people in non-persistent poverty, their realities are different. Why would you want to do that? So in rethinking our approach, we need to encourage within subgroup comparisons. And we have the Native American program, for example, which doesn't allow comparisons outside of the same community. And as I mentioned to you, we have the Rural Health Control Program. We have to allow for innovative intervention designs, quasi-experimental. When we say we're doing multi-level factors, you should not require power calculations which take all those factors into account. Then your cell size is 5, and that's not feasible. We have to build partnerships and sustain them to identify the gaps and do what the community wants us to do. And I don't think we can move the needle if we don't do that. Oops, keeps going backward. So we would love the development of theory and evidence-based multi-level population community interventions that target both structural and individual factors. So this is taking into account intersectionality. What are new measures on inequity and the social environment? What measures need to be adapted to the existing measures of SDOH? And how can we understand these pathways? How can we do research in small populations that are largely excluded from clinical trials because of the limited size of these populations? I'm always thinking of that. You're only as good as your weakest link. So unless we look at all these intersectionality, these health disparities will continue to exacerbate. And that's it. That's all I have for you. So I'm going to stop sharing.
And I turned off my mute. We're a small group. Go ahead and ask a question. You can unmute yourself and speak with Shobha.
Hi, Shobha. My name is Ashwini Rajput. I serve as the director of the Kimmel Cancer Center in DC, and I really enjoyed your presentation. I've been here for 2 years and I actually came from the University of New Mexico. So I enjoyed seeing your slides about the success they've had with the Pueblo populations and the Hispanics. In one slide, you showed there was some exclusion criteria for certain populations, and one was DC. Could you expand on that for me? Is DC excluded from any grant opportunities, or what's the issue there?
No. The issue was when we define subsistence poverty, is generally defined at a county level.
Right.
So when it's defined at a county level, places such as DC are excluded from it. So what we did was now defined it at the census tract level, and places such as DC are now included in it.
Perfect.
So that's what I was trying to say.
Thanks
Sorry.
for that clarification.
Hi,
Otis.
Shobha, Otis here. I just want to
Hi,
thank
Otis.
you. I want to thank you for doing that census tract thing. That is really, really important to us. And you know, I admire your work. You've just done extraordinary things.
Thank you, Otis. Coming from you, I am totally humbled and touched by it. You are a stalwart in this area. So, you know, I am really, really deeply humbled by your comment. Thank you so much.
So Shobha, just to let our audience know, the only persistent poverty census tracts in Maryland are found in Baltimore City. And there's just a few of them, yes. So
Yeah.
Hi, this
I
is
mean, you are right where there is poverty, just around you. I'm sorry.
yes. So Claire has a question.
hi. I had a couple questions related to the NCI or NIH process, because as you mentioned, it doesn't really matter how the NCI staff feel about it. If reviewers are going to take this into account, then we're just banging our head against the wall. So what does the NCI propose to do so that reviewers don't, score proposals poorly, that have small sample sizes, that might not have power, that, have all of the limitations that you mentioned? And then I have one other follow-up question, but I'll do one at a time.
Claire, you bring up an issue which is very close to my heart and very difficult to deal with. We've recently written a paper for AJPM, and with Bob Croyle, I think it's his last paper as the director of the division. And the issues we bring up is the issues that I have raised here. And we are hoping that we can circulate it to everybody to kind of really think about what is it we're really trying to do. And I think at every level, we have to educate people. My next agenda is to talk about these biases and methodology at every meeting that I attend. I'm going to be talking about it at ASPO, at the Latino meeting, which is coming up. The issue is we really, I agree with you, we have to educate people.
Thank you for that. And my second question relates to funding announcements, because I know that the NCI has moved to these notice of special interest. And I'm wondering if there's any data that suggests that if you respond to a notice of special interest, it's any more likely to be funded than if you don't, if your grant is not related to a notice of special interest. Because I think that's another area where there's this huge disconnect, where the NCI says, hey, we're interested in something, and reviewers make their own calculations.
Actually, it doesn't. The data doesn't show that. It just
Doesn't
shows,
show what?
It doesn't show that if you do a NOC versus a PI-initiated application, your rates of success are different.
Okay, so there's no clear advantage to responding to a NOC.
No, there's no clear advantage. If you think about it, when things go to CSR, there's about 100 applications, and there may be like 25 no-sees that they're responding to. I don't think the reviewers are reading all those no-sees.
Well, thank you for
It's
the,
left with the PI states that I'm responding to a no-see, but that and $3 buy you a cup of coffee, basically. It's not like it changes the way they review the grant. I haven't seen that.
yeah, so I think until you can get more RFAs and PARs, it's going to be hard to move the needle on this.
And I also think there has to be a push to get more special reviews. You know, especially, I think of SGM and I say, you know, I need a special review for it, because I don't think everybody gets the issues. If it is HIV/AIDS, it is rectal cancers, they get it, or smoking. Everything else, they think everybody is the same. I'm like, how can you say that? You don't have the data on it. So how can it be the same? You're just assuming again.
Allison, you have a question?
Sure. You mentioned the U54. We had talked with the group, Otis included, a couple months ago about the NOC for the PO1. So is that U54 has it been released? Is it along the same lines? Because or
Well, it will. A U54 mechanism is, I would recommend, Otis is privy to this. He was one of the reviewers of the persistent poverty concept. He knows exactly what's going into it. But I would recommend that you watch the BSA NCAB section of it, and we lay out what is going to be in it. So basically it's 2 projects: having a research core, an administrative core, and a training core.
okay.
And we talk about the budget layout in it and those kinds of things. And it's going to be from the census tracts that are in persistent poverty, which we're going to release earlier.
Okay, that's helpful, because we were thinking of putting in for a PO1, and we're in the planning stage, getting together focus groups, but we were also very interested in including the NCR region. So that would be, because it's very complementary to Baltimore City. So thank you.
You're welcome. The PO1 will still be on the street. It's got another 2 years to go.
Okay, and that will stay limited to the counties though.
We will kind of switch it out. I'm planning to do a release when to do it at the census tract level, either county or census tract. But the U54 will be restricted to census tract only.
Okay, great. Thank you.
You're welcome.
Okay, other questions? Whoops. Other questions for Shobha? Obviously, a few people have been thinking about this and how, you know, even anticipating applying. So, Shobha, do you have the URLs that you could share with us for these particular grants that people might be interested in?
Which grants, Norma? Which ones are you talking about?
Well, I'm not privy to it. I'm not familiar, but I'm thinking of the U54 and the PO1 that you and Allison were just mentioning.
Oh, I can send you the PO1 NOC. Yes, I can send it to you and you can share it with the group. The U54 has not been written yet. We just got approval last Thursday. I don't think it will be released till February. According to federal rules, you're supposed to have everything in the system for 1 month, and we're trying to have other institutes participate in it. So it's going to take a little while to do that.
I see. So Allison, a follow-up? Oh, unmute. Allison,
I think that was up from before. I don't think it went down. Sorry, I didn't unraise.
Okay. And Elizabeth.
Hi there. So I'm currently teaching epi methods to students in departments who are not in the Department of Epidemiology. This is going to make sense in a moment. And one of the things we've been talking about is external validity, generalizability, and the fact that we don't always do large prospective cohort studies and consortia. Sometimes there's a problem in a particular community. It could be physical space, geographic space. It could be characteristics of persons. And the way that we approach our research actually is quite different, right? So if you're trying to generate sort of just general foundational big picture knowledge, we use one style of research and it has to be appropriately powered, right? When we want to solve problems in certain communities, it's a very different style of research. It often involves new recruitment of participants, right? Getting buy-in, making sure what you're going to do actually addresses the concerns of the community. And as I listen, NIH grants don't always seem to be the right mechanism when you're trying to solve something that's very specific to a community for the reasons that Claire raised. Power may still be an issue, right? These may be very small subsets of people, and what we learn will fix the problem in that community, but it may not, it's much more applied, I guess is what I'm trying to say. And so power may not be there. Reviewers don't always get it. It's exactly the issues. So what are investigators supposed to do? So some are still doing the big consortia of people who are basically white and better off, you know, and they think they're developing foundational knowledge, right, that may be broadly generalizable, but it may not be solving community-specific problems. Community-specific problems, grants addressing those tend not to review as well for the reasons that you said, that they are viewed as not generalizable, may not be sufficient, you know, value for our public health dollars, whatever the concerns were. What should we do as investigators? I'm just going back to what Claire's saying. I'm just trying to break it down into this sort of broad, big picture kind of research that may not solve particular communities' issues, but it contributes to the literature versus really trying to do applied work to solve problems. Are they different kinds of funding mechanisms? Are they different sources of dollars that need to go to support those two different styles of research? Or am I just making stuff up that doesn't even make any sense?
No, it makes a lot of sense. This is something, capacity building is what you're asking
yes.
about.
Yeah.
And that is a very difficult agenda. NIH has these capacity building, which it only focuses on training for a large part. And it's a very tall order. And I understand that. Kind of say, you know, you have to build the capacity and know exactly what you want before you come in for a grant to NIH. Like we say, oh, we want CVPR, but at the same time, you have to come in with the community, with a particular agenda to address the issues in that community, right? So nobody is paying you for that first 2 to 5 years of building capacity and building those connections. So one of the ways that NCI has dealt with it a little bit, and we're trying to formalize it much more, is the COE, that is the Community Outreach and Education Core. In cancer centers, they have that. And now they're asking them to define the catchment areas. And we're trying to kind of work at least formalizing them much more. So the funding that we gave to persistent poverty areas, the CCSGs that I was mentioning, was kind of like a capacity building for research. We did that 2 rounds to rural, for CCSGs in rural, working with rural areas. And we spent like $10 million on it to build the capacity before we put out the RFA. But it's not always successful, and it's not really something that brings everybody into the fold. And I agree with you. We used to partner a long time back, and Otis would remember this, with ACS, and people were allowed to put in grants simultaneously to NCI and ACS, and ACS used to pick up the capacity building, and we would pick up the research end of it. It was fabulous. But, you know, that's not possible anymore. Do I have an answer for you? A direct answer? No. I have no idea on how to do it. And it's part of my frustration too. I came into NIH because of that frustration. My dean told me one day, he said, you write nasty letters to NIH, why don't you go change it? And it's not like it's going to change easily. I don't think, yeah, even the Unite committee is not doing that. I'm sorry, I don't have a good answer. The only is CCSGs and what they can do for us, which doesn't help either because they're not there in areas of extreme persistent poverty.
Shobha, I have a question for you based on your map of the states with counties having persistent poverty. And a number of them are those states that haven't picked up the Medicaid expansion. And so that would be very helpful in addressing medically underserved populations. And I wondered, had NCI had thoughts about this, or somehow incentivizing proposals that would work to change state policy in this area?
We don't do work to encourage states to change their policy. We're not allowed to. But I would love to see CCSGs accepting Medicaid. I can't understand why CCSGs, cancer centers won't accept Medicaid. I just cannot understand that. Alabama doesn't accept Medicaid, the cancer center there.
Yeah, I'll tell you, the problem is when you accept Medicaid, you're buying into what I would call a Robin Hood maneuver. We accept Medicaid at Hopkins and we lose money on every Medicaid patient that we see.
Okay.
And we're only allowed to keep our doors open because we make money off of every insured patient that we see. And so that becomes the problem. And if we didn't accept Medicaid patients, things would be a lot easier for us budgetarily.
Yes, but I feel that that's what we are here for. I mean, we have to. It is taxpayer money.
Yeah.
It is. We have to be able to open the door to everybody.
My friends at UAB would say, not that they should accept Medicaid, but that the state of Alabama, which determines Medicaid payment rates, ought to pay what healthcare actually costs. But quite honestly, I don't know of a single state that reimburses Medicaid at what healthcare actually costs. Some states take a bigger discount. Alabama takes a huge discount, much more so than Maryland.
Yeah.
And Ash, I don't know what DC does.
Don't know either.
In terms of the cancer center here?
No, for Medicaid, how big of a haircut do you guys do take Medicaid? I know that, but how much of a haircut do you take with Medicaid?
I think it was a slight trim from what I saw last time. It wasn't a fade.
Yeah, in Georgia, where I ran the cancer center at Emory, Medicaid paid 50% of what Blue Cross paid. That's a real number. And Alabama's worse.
Yeah.
Does Medicaid not participate in the Maryland all-payer process?
I don't know I don't know how that works. I know that we accept Medicaid and we don't get paid what the blues and other insurances pay. But I don't know the answer to your question.
Yeah, they set their own rates, the state does, for Medicaid. And the Cigarette Restitution Fund public health grants actually reimburse on the Medicare rates rather than Medicaid rates in Maryland. So there is still quite a difference. Okay. Yeah, I just thought maybe some of the community's concerns could be solved with a policy insertion. All right, well, Shobha, thank you so much for coming today. This has been a great little discussion here. We will let everyone know, you know, the proposed solicitation number for that grant that's out there. And of course, we'll watch for the release in February for the census tract interventions. And this program will be posted on our YouTube station. So we'll let you know about that also. And thanks everyone for participating.
Thank you.
Bye. Bye-bye.
Thank you so much. Bye. Thank you.
Thank you.